I love that. I love that voice. This meeting is being recorded. What's up, Dave?
Oh, nothing much.
How you doing?
A lot of things, actually. Yeah.
Yeah. You doing? You doing okay? As good as possible, considering the circumstances.
We haven't been hit hard yet, so right now we're fine. We're barely working overtime at all. It's okay so far.
We'll get into exactly all that stuff in a little bit, but Dave Thibault, how long have you been a member at NCR now? I forgot to look that up actually. A little while.
I think 3 years and a bit, maybe 3.5.
3.5 years at NCR.
It always seems so much longer than what it actually feels like.
I know. Like there was someone who said that they were only a member for a year, and I was like, "Frig, it feels like it's been at least 3."
Yeah, I know.
We really get to know people, and then we feel like when you know how someone squats inside and out, you're like, I know this person. I've known this person for a long time.
So Dave, you're an ICU nurse by trade. That's your profession. You're an ICU nurse, and obviously, this is a super relevant time to be having a conversation with you. We wanted to have you on because we wanted to give people a little bit of an inside look into the front lines and sort of give people a feel of what's actually going on. Obviously, there's a lot of articles out there. People are being interviewed left, right, and center, and we thought it would be appropriate for us to share with everyone someone from our community who is about as close to the front lines as you can possibly get. I think as an ICU nurse, you're exposed to coronavirus more than anybody. So why don't you start by just giving people a description of what it is an ICU nurse does? Like if I have no idea what that is, like how do you describe that?
Well, I'm just going to start off by kind of prefacing this with the fact that, I'm not a critical intensivist. I'm not an epidemiologist. So everything I'll be talking about today is obviously my perception from anecdotal experience. So I just don't want people to take what I'm saying as like hard scientific fact, right? Just putting that out there.
For sure.
It's just the NCR podcast. I think if anybody takes this podcast with any scientific fact, they're screwed anyway. So
yeah, that's fair. So an ICU nurse. So normally we only have 1 or 2 patients, usually 1, sometimes 2 patients if they're a little less acute. Our shifts are all 12 hours, 7 a.m. to 7 p.m. or 7 p.m. to 7 a.m. So my unit particularly, we deal with a lot of patients with respiratory problems and a lot of the hem-onc patients. So people with lymphomas and leukemias, BMT. So basically very sick hematologically, patients with no immune system as well. The civic hospital, I don't work there. They're more neurology and trauma. But basically, we go in for the morning at 7 a.m. We get our report from another nurse for about 20 or 30 minutes. We kind of break every individual into systems. So we talk about their neurologic status, like where are they at mentally, what kind of medications are they on, sedation, pain medication, are they alert, can they communicate with you, how are their lungs doing, so we do like a respiratory assessment. So we get all the information of what happened overnight. And then we go in, we do our first big assessment. And every day the doctors come to each room and they kind of they discuss what happened overnight or during the previous shift. And they create a plan for the next day and what to do next, basically. So that's kind of what we do. Yeah.
That's really cool. So what sort of designates where someone's going to either go to an ICU bed or like a regular bed? Like what's the difference there? Like if I go to the hospital, why would I get admitted to ICU versus a regular?
So you go to the ICU for a few reasons. One is if you need to be on any really basically medications that can adjust your blood pressure, because when people get what's called septic, when they get infections in their bloodstream, their blood pressure can drop, and that can kill you. So you need to give people medications to increase their blood pressure, and that needs to be monitored very carefully. So if people have these really bad infections in their bloodstream and they need these medications, they come to us. If they're having really bad breathing difficulties, anyone with a breathing tube goes to the ICU, or anyone who might need a breathing tube will come to us as well. So it's mostly blood pressure medications and respiratory issues. Kind of primarily, those are the big things, I guess.
Cool. And like I was talking to Jen obviously earlier about this podcast that we were about to have with you. And those of you who don't know Jen, if you're listening to this, she's my wife. She's a family doctor, and she was talking about how knowledgeable ICU nurses are in terms of the medicine itself. And I was just wondering what drew you towards that side of nursing. Like, what kind of got you in there? What kind of drew you into ICU nursing?
I don't know, man. I actually I became a nurse on a whim. Like, I had zero, like, I was working in the music industry and I quit, and then 3 hours later I'm just like, I'm gonna be a nurse now. I used to like try to control life, and then I'm like, life is chaos, just trust your gut. And it was a really weird process. I don't know how, I can't really explain it. But ICU, I think that like I'm really bad at multitasking, and I don't know, it's just a little more interesting, you know what I mean? I just got kind of the good thing about ICU is you have one patient, so you have the time to do things properly, you know what I mean? Like, a lot of people that work on medicine floors, people don't understand that you have 6 or 7 patients, you're running around. I think their job is harder than my job. It's underrated. It's very, very difficult. So, you know, if my patient's getting better, I have a whole day with one person. I can give them a good bath. I can make sure they have all their meds. We can mobilize them, get them moving. Like, they get good care because we have the manpower. Other floors don't have that. So
I guess that kind
of
an
ICU nurse.
Sorry,
yeah.
Go ahead, PT.
I was going to say, like, and where does the ICU nurse career path, or when do you go into that direction? Is it something that you can just go into as soon as you become a nurse? Is it kind of a department that you apply for, or it's a department where, you know, you have a competition to get into? How do you get there?
So what happens is, like, I was fortunate in that my last semester of school, I was on this unit for my last placement. So I already had 3 months experience there, and they were hiring. So I basically was just handed the job. However, if you want the job, you have to, there's about a 6-week course they take you through. So it's a critical care course, and they break it down into a bunch of different things. But basically, it's a month and a half of intense, like 40 hours a week training, and then about a month with a buddy. So you're looking at over 2 months of training before you can just hop in. Yeah.
And you've been at the Ottawa hospital since out of school?
Yeah. Same job. This is my only job that I've ever had. Yeah.
And how long have you been doing it for?
Almost 4 years.
Okay, right on.
I guess that kind of explains what you were talking about. You were saying, like, you know, you're the only person on that bed, and you feel lucky in a sense compared to some of the other nurses, because you've got all day and all time to sort of assess your patient and all this. But in the news, we're hearing about you know, how expensive intensive care units are for hospitals. I guess that's one of the reasons why, is because you're assigning professionals to the care of one bed for the entire day versus one nurse to a whole bunch of different beds.
Yeah, that's the cost is associated with that. The cost of the medications, the cost, just the actual room. Like, it's incredible. Like, don't quote me, but I think on average it costs like $3,000 to $5,000 for 24 hours in the ICU or something like that. It's insane.
Wow.
Yeah.
Wow. And I guess that the training for the expertise, actually, you know, performing like the medicine in there. Like, obviously you just said that you have to do if you're not in your situation, you have to do a 6-month training to be a nurse to go into the ICU.
Not 6 months, like
oh.
2 months.
6 weeks.
Oh, 2 months, 6 weeks, 6 weeks. Okay. But I would expect that the doctors who work in ICU also have extra training.
Oh, the doctors are insane. Yeah, they've got like their 4 years of med school, their 4 years of critical training, a few years of fellowship, and then you have the staff doctors on top of that. You're looking at 15, 20, 30 years. Yeah.
Wow.
Like,
So
it takes to be like, so the way the doctors work, you have like the attending who's like the head honcho, and then you have fellows who have like their 4 years in critical care plus a few years of critical care fellowship. And then you have residents who might only be like a second year ophthalmology resident, right? So they're much like, in terms of their knowledge, experience, it's much, much lower. Yeah.
So I guess that's what we're talking about, and when we talk about the hospitals potentially being overcrowded eventually when it really hits us, is the fact that I never even thought of that, how there's one nurse and per patient in the ICU, and if everyone or more people than normal end up in the ICU, then that's where we get into some issues, right?
Yeah. So the biggest issue is that right now, like, there's no cure for COVID, obviously. So it's basically symptomatic care. So we basically support people until their body heals itself, right? So if someone comes in, for example, with an infection, we intubate them, give them antibiotics. Within 4, 5, 6 days, they can be better. We can pull the tube, they can leave. With this, people might have the tube in for 2 or 3 weeks. So once they come, the bed gets full, and that's it, right? So the movement out of the unit's so slow right now. So that's a huge issue right there.
Is there, do you guys have like a protocol? Like I mean, obviously you do, but what does that protocol look like for when things, because it's still pretty tame here in Ottawa. But I remember talking to one of the mothers of the teens who comes to NCR, and she works at CHIO. And I remember like CHIO is prepared to take on adults. So like, what does the protocol at your hospital look like for when things get hairy?
Yeah. So like you said, it is pretty tame right now. Like I said, like I just worked 4 shifts in a row. I'm off for 4 days right now. You know what I mean? I'm working 40-hour weeks right now. It's okay. It won't be okay soon though. It's coming. But we have a ton of like kind of what ifs in place right now, like contingency plans, if you will. Our unit has 28 beds. The plan is to build up to 90, which is more than triple capacity.
Wow.
Yeah, which is scary. So the way this is working is that, first of all, because the hospital, like the operating rooms are kind of reducing their workload. They're only doing like, obviously necessary surgeries. So a bunch of these operating nurses and endoscopy nurses are kind of free. So they're going to be coming to our unit. And the ICU nurses will be training them, because only about a third of what ICU nurses do is ICU specific. So other nurses can do a lot of things for us too. So the plan is to kind of, instead of me having one patient, I might have 2 or 3 or 4 patients, and then I'll be delegating work to nurses from other floors. So that kind of, it'll be like almost like a hierarchy of like a respiratory therapist and a nurse from the ICU with 2 different floor nurses and 4 patients. So it's like a pyramid. That's kind of the plan. We're going to double up our rooms, extend to a different unit next door. So that's kind of what's going to happen at this point.
And I guess something we were also curious about, and just like, it's good to hear your take on it, is personal protective equipment. Like, do you guys have a bunch at the hospital now that you guys are planning on like kind of just saving for when things get bad, or is there a protocol already in place?
So far, I can honestly say we've been protected so far. I've had everything I need to this point. I don't know what the next few weeks will look like. It's a big concern.
And listening to you talk about even having to just train the other nurses, like, on the subject of personal protective equipment, this seems like obviously why it's so important for you frontline workers to have the equipment that you need to protect yourselves. Because if one of you guys get sick with this, and all of a sudden you can't even train other people, our hands are basically tied in that unit, and there's a lack of knowledge there where to even run the unit properly. Am I right on that?
Yeah. So it's already been like, we're going to lose probably up to a third of our staff consistently on sick leave. So we're going to be working at 70%. But of course we'll be getting people from other units. So I don't know how that will all work. But yeah, I mean, I find that like the issue with the protective equipment is that, like, for example, like if someone gets exposed to this by accident or if something happens, they take 2 weeks to isolate at home, right? Or if someone doesn't have COVID and we realize they do have COVID, anyone who's exposed to them during airborne procedures has to stay home and monitor. So we can lose, 10 people in a second for 2 weeks, right? So the staffing is a concern, obviously. So far it's been fine, but I mean, again, like I said, it's not bad yet. It's still, we're just getting started right now. We're ramping up.
Is there what's the ideal personal protective equipment? What is going to keep you safe? Because I've been having this talk with other friends of mine. Like, should I be wearing a mask when I'm in public? Like, what is going to keep this away from you?
So again, this is like from like for what I do at work and for what my managers and supervisors and the hospital has said, from public health professionals. I'm starting to get a little more comfortable with the rules because one of our top ICU doctors, like he basically runs the Ottawa ICU in our unit. And this is from the guy that trained him, who's an epidemiologist. So like, this is like information I trust as a nurse. This is primarily droplet. It's like the flu, right? So it's like, so keeping your distance, like, unless you're doing specific procedures that create aerosols from your mouth, like in the hospital, or someone's coughing like crazy, it's not really floating in the air. The droplets kind of fall as far as I've been told. So in general, like if you're going out in public, you're going to the grocery store, you want to know what to do. Wearing a mask will stop you from getting other people sick. It doesn't protect you really that much. Yeah. So like for me in general, when I'm at work, what I'm wearing is a gown. Like I spent the past 4 days all with COVID patients exclusively. A gown, basically a face mask, just like a droplet mask. It's not an N95. It's not an airborne kind of particle blocker, just a regular mask and then a shield. And that's kind of the standard. And if you're doing intubations and things that can cause aerosolization, you'll wear the N95. So if you're an average person going out in public, the mask you wear will protect other people from you more than you from them. But also, if you keep the distance, you should be fine. Basically, go out once a week, get everything you can.
It's probably a good reminder too, just not to touch your face, right? I mean,
it's hard.
I think
hard not to. It's hard. People do all the time.
I know, man. And you know what? Through these podcasts, I realize that I'm always like,
yeah.
When I was in school, they did a little joke on us where they put this like paste on the doorknobs to the classroom, to the amphitheater, and it glows in black light.
Oh, no.
And no one knew. So we go into class, and basically they were talking, and then halfway through they were talking about the importance of hand washing, and they turned the lights down and put the black lights on, and everyone looked at me and laughed because my whole face was white because I was rubbing my face for half an hour. So yeah, it's hard not to. It's hard.
Dave,
right now, you just wipe your face. Wipe your nose.
Oh no, I know. I just did like this, and then I touched my hair. It's over. I'm done. I got COVID. But let's. You say you're working exclusively with COVID patients, so talk to us about what they're going through from your point of view, your perspective, and what kind of care they're getting and symptoms or whatnot. Talk to us about that.
Okay, so symptoms, there's a lot of symptoms. The big ones they always say is like a cough, basically. Apparently a really, really big one is like myalgia, so muscle pain and headaches, bad headache. That's huge. We talk about smell and taste, like dampening of your sense of smell and taste.
Yeah.
But apparently there are other ones too. There are like gastro issues, like upset stomach, stuff like that. And obviously fevers, but a fever isn't like an end all. Like if you don't have a fever, don't rule it out. You know what I mean? Apparently about half of people present to hospital with a fever that have it. So it's not like if you don't have a fever, you're fine. Like don't have fevers alone. But yeah, there's a lot of different symptoms.
Do you notice that like some of the population deals with it better than others? Like you said you've seen a lot of patients. Like I'm just thinking, are the are the guys and girls in their 40s dealing with it worse than the younger part of the population that has it? Like what does that look like?
You probably don't see those guys.
We see anyone who's really bad, right? Anyone who's like really, really sick. Doesn't matter how old they are or whatever.
Is there a trend in who you're seeing? Or
absolutely, yeah. What's really, really kind of interesting is that when they compare like the underlying health issues that make that give you like a link to a worse prognosis, it's actually more cardiac and like metabolic issues versus respiratory issues. So if you have hypertension or diabetes, that's almost worse than if you have like COPD and you're a smoker for your outcome, which is super strange. So
why is that strange? Explain that.
Well, you would think that someone with COVID, which is like a respiratory illness, would be much worse off if they're a big smoker and have lung disease.
Right.
But if you have heart disease or you're diabetic or hypertension, which is like a cardiac issue, it's worse almost.
Mm-hmm.
So I don't know why that is.
Does it have something to do with their immune system potentially, or someone's immune system is worse?
I don't know. I can't even tell you. Yeah. But so the people that come in that are super sick, I'm going to tell you right now, the ones that, we only have a few right now, but they're either immunocompromised severely, they're older, and they're like what I would consider quite unhealthy. I haven't seen anyone under 50. I haven't seen anyone, the majority, I'm in the ICU. I have a handful of patients. I can't speak for the whole world or the whole country, but from what I've seen, these aren't people, they're older and they're naturally more sick. I don't know what to say. Like they have other issues too. There's no one I've seen that's 35 yet or 30 who has like no health issues who's in here on a ventilator yet. They will come. They will be much less common, but they're going to come. So.
I heard on the radio that Ottawa is not expected to peak until like summer or early fall, which is like crazy.
Really?
Yeah.
I don't expect to see my parents for a year. Yeah.
Speaking of that, like how
get used to this, man. Like fine. I'm reading about house buying, about pensions. I'm learning some shit. Like we got lots of time to kill. So do all those things you couldn't do before because you had no time, because you have time now. Okay?
Dave, you're living with your fiance.
Yeah.
You're on her account.
I'm on her account. Yeah. My phone's glitched up. I need a new phone, so it's gonna freak out.
Like I suspect that you guys are doing some sort of social distancing at home or what?
We don't see anybody. No one.
Like you guys, so basically you've considered, to approach the situation correctly for you, because you're seeing COVID patients on a regular basis, you have to essentially assume that you're infected.
Right. So I 100% assume I'm an asymptomatic carrier. So I will literally not see any humans outside of work and Cheryl for the next 8-12 months. I don't know how long it's going to take. Yeah. And
is Cheryl considering the same for herself?
Yeah. Oh, she's been doing it.
Yeah.
Yeah. She feels the same way. She knows that, because she's pretty much me, right? Because I'm out there, I come home, she's around all day, every day. She has to assume that, So
you guys have basically made the decision, like you've made a decision. She'll be in your germ bubble for the duration, as opposed to.
She accepted it.
Yeah.
She's been good about it. She's been saving me, man. I come home from work. I got a bubble bath and a glass of wine and like a nice, stable pretty great. She's really bored, so she fills time with, right?
That's awesome. Well, if she's really bored, tell her to hop into some of our virtual classes.
Yeah, exactly. Dave, are you scared at all of going to work? Like, what goes through your mind when you know that you're closer to this thing than anyone else on the planet?
There's like a weird, I'm going to say right now, like all of us, we have this, like, I feel almost like bipolar. Like within a single day, I'll go from being really, really confident in the way things are going and comfortable and safe, being like paranoid and panicked and back. Like it's a roller coaster emotionally, especially for, some of my coworkers who are 60, who have health issues, who have families and husbands who are in their 70s. Like, I have no kids. Me and Cheryl are healthy and young. We don't see anybody. So we're kind of okay, but it's a weird time. I'm not that concerned for myself personally, but the issue with if we run out of like equipment, I just feel like it's silly to go in to a room to save a person, to get infected and spread it to 15 people. You know what I mean? So yeah. It's kind of like the team we have is incredible, and like everyone's willing to work 80, 100-hour weeks, provided they give us the bare minimum support and equipment. You know what I mean? So it depends. We'll see how everything goes. I'm sure I'll have a lot of changes will happen next 2-3 weeks. But
and I mean, I know Justin Trudeau and the government is talking every day, and Ford about turning these factories that we have in Ontario and Canada into personal protective equipment manufacturing centers. So hopefully we can like make quick enough to get to all you guys as soon as possible.
Yeah, I feel like we're in this weird like transitional state where it's going to be bad for a bit, but then once we've ramped up the production, we'll have enough of everything. But there's going to be like this like little month right now where they're not quite set up to make the equipment. But I feel like in a few months they'll have everything lined up and we'll be much better off. So we'll see.
So Dave, you go to work and you handle patients with COVID all day longer for 12 hours, and then you come home and you probably turn on your phone and then see COVID on the news and COVID on Instagram and this and that, and everyone's in quarantine. Is there something that you do when you're not at work to kind of like get your mind off it? Because if I was in your position, it would drive me nuts.
This isn't coffee, so. It's actually a beer. I was going to tell anyone, but now at this point I still have to.
Fuck it.
It's like, it's pretty stressful for sure, but it's kind of weird too, because I find that like for me anyways, life has gotten very simple. I go to work, I come home. There's not a lot to do outside of work. So I'm one of the, like, in a way I get to socialize at work. So I'm not like going stir crazy, which is good. I have job security, which is nice, obviously. And I don't know. I'm actually like, my sleep debt is gone. I've been napping an hour and a half every single day I'm off, because I'm like, you can only watch so much with me, right? So like physically right now, like I feel like if I went back to the gym, I'd be hitting some PRs. Like, I feel really
That's good to hear, man.
For me, it's been pretty good, but it's different for other people. I have it pretty easy right now.
Yeah. Well, I feel like you're a pretty easygoing guy, happy guy. So,
yeah.
Have you been playing any music?
Oh, I've got, I'll have a basement studio set up in a few weeks. Yeah. I got all my gears getting set up for sure. We're still having a jam session once this is all over, right?
Absolutely.
Big time.
All the really bad pop punk. Yeah.
Exactly.
Yeah.
Are we gonna do Intergalactic?
Sure. Reza, you can play bass. No one likes the bass player anyway.
I'll sing. I'll sing.
No, he just doesn't look cool, That's cool.
He raps.
Oh, I was there.
I saw it. If we could get a little mix of what's like a good band that raps and sings, like Linkin Park.
Yo, one of you can scream like you smoke 6 packs a day, then sure, yeah.
That's so funny.
One of us needs to get COVID, so it messes our throat up. We can do that, you know.
Dave, we made
Too soon.
obviously you saw the Instagram post that we made featuring you and your home gym, or no, it was a frontline worker post, and we were highlighting, you know, this job that you do and everything, and how much we appreciate it. But I don't think I even knew that you played at Warped Tour in two different bands. What were the band names?
No, just one band.
One band. Oh, okay. Or
And
you played twice.
You're not gonna get to know the name because you might find it and it's not good.
Come on.
I need to know now. Now I need to know.
Come on.
I'm cutting that off, man. Cutting that off right now. Hard.
Okay. If someone out there is eager enough, they can dig.
But I don't want it getting out here and everyone can. No, it's bad.
What's your instrument?
Guitar and keys. A lot of synths, yeah.
What's your favorite band nowadays?
Right now?
Yeah.
Man, what am I listening to right now? Jeez. I don't know. Royal Blood's sick. I love those guys.
Royal Blood.
Sounds heavy.
Yeah.
Is that?
Sounds heavy.
No, it's like bass and drums. You know their stuff. It's like Death from Above a bit. It's cool.
Okay.
Okay.
Cool.
Nice. Yeah.
It's not like metal or anything. It's catchy. It's hooky. It's good. I'm trying to think. What do I listen to? I want to calm down. Little Fleet Foxes, maybe. You know, bring it down.
Yeah, that's good.
Little old school Feist just to put you to sleep. You know.
Love it.
Some Radiohead Amnesiac, Crazy Dreams. You know.
Oh yeah.
That album's good, man. Yeah.
Well, that's when Radiohead really went nuts.
Exactly.
Or Kid A? Was it Kid A?
Yeah. Okay Computer, I think.
Okay Computer was like their last like real music album, man. After that, like
it started getting weird, and then it got weird.
Yeah.
Dave,
Paranoid Android came on the speakers. One of the last times that I was at the gym with Reza, and I usually make fun of his music when he coaches, but this time it was like this song, man, like that's in my top 10 songs of all time. Paranoid Android.
You should probably stop making fun of Rez and save that for Derek's music.
Oh, yeah.
He's not even here to defend himself right now.
Yeah.
We'll text him after. We'll let him know.
I'm on a mission right now to try and find your old band name.
We'll find it.
I'll find it.
Yeah, we'll find it and we'll post it with this podcast.
You will find it. You will.
Dave, how did you find CrossFit?
Val. So Cheryl's cousin.
Oh, okay.
Right.
Val May.
She was coming to our gym, and then you tagged along. Did you do any working out before CrossFit?
Well, I thought I was. Now that I know what working out actually is, I wouldn't call it working out. I was playing with weights, I guess. Yeah.
I love that. Are you
You've
doing
been a member? You've been a member since October 2016. I just looked it up.
Are you doing any WODs at home?
Yeah, for sure. I did yesterday's.
Nice.
That was hard. I used 35s for the thrusters and lunges. That was painful.
Nice. And
Amazing.
you ran outside?
Oh, it was outside. Yeah, it was nice out yesterday.
Yeah.
Okay, you can't say no. But is the name West in your band name?
No.
It's not.
I promise. No.
Okay.
Keep going though. This is fun. Keep trying.
We'll find it one day. Any other questions for Dave, PT? Rez?
I'm on a mission right now, man.
We're gonna find it. We'll find it. Dave,
David,
really appreciate you sitting down with us, man.
Anything you want to say before we sign off, Dave?
Basically just I know like the whole social distancing is being reiterated 100,000 times, but you know, like some of us, we have to, because people that have COVID, their husbands and wives and family also probably have it. They can't come. We have a no visitor policy. So you know what I mean? Like we're holding iPhones and we're holding iPads basically with the family, and we have to show the face of this person who's about to die, and that's their goodbye. So when people are sick, they're sick. And, you know, until you know someone who's suffering from this, it's, you know, it's just all theoretical, but you know what I mean? Once you have to experience it, it's some serious stuff. And most of us, the younger people, the healthier people are going to be just fine. But you're not doing this for yourself. You're doing it for other people. And just, you know what I mean? Like I said, I won't be seeing a single person except my girl, except for Cheryl. I won't see my parents, my brothers for a good year. And that's just how it's going to be. So, you know, if I can manage that, you can stick to your small groups and, you know, do your best or whatever.
I think that's very well said, man.
Yeah. Well, dude, we appreciate everything that you're doing for us. I'm sure everyone else in the community feels the same way. And I hope people learn a thing or two from the podcast, if it's just you know, what it's like on the front lines, and hopefully it can hit home just a little bit more, even if it's just a couple of our own members who know you personally, and you know, just a little extra motivation to stick to this social distancing stuff and you know, stick it out for just a little bit longer until things, you know, blow over.
Well, yeah. And one more thing, it's just an interesting thing. This whole social distancing thing, do you guys know about what Sweden's doing right now?
Yes,
Yeah.
we heard I heard for the first time the other day.
Yeah. So they're basically trying to keep the country going and create, you know, legislation and like protocols to keep the elderly and the more at-risk people separated. So, I mean, it's a risky business, but they're the only country doing it. So if you're curious to see the difference between social distancing and not doing it, the next few weeks, keeping an eye on them will be very, very interesting. It could be terrible, it might do nothing, and it might work, but it's something to keep an eye on. It's very, very interesting. They're the only people doing it, right? So.
Well, the UK is kind of an interesting case because they started out that way and then quickly made a 180.
Yeah, exactly. They shut it down right away.
So
yeah.
the effects happening there are just a little bit more towards that notion that you're just talking about with Sweden. But yeah. All right, Dave. Well, it was great talking to you, man. Thanks a lot for coming on.
Thanks, Dave.
Stay safe out there. Enjoy the beer, and we'll be thinking of you, buddy.
Take care of yourself, guys. Thanks.
Yeah.